Welcome to a crash course in pediatrics. My name is Dr. Shahid. I'm a general pediatrician and medical educator. CRASH stands for Clinical Reasoning and Analytical Skills with Shahid. The goal of this course is to teach clinical reasoning skills to medical students and residents. Today, we're going to focus on diagnostic errors and why a physician might miss the diagnosis. So why did I miss the diagnosis? Looking at how doctors think. I want to start off with a quote from Sir William Osler, where he said, "If you listen to your patient, they will tell you their diagnosis." So our patients are telling us their diagnosis. We just have to make sure that we are listening to our patients. So the objectives of this lecture, we're going to use pediatric cases, and through those pediatric cases, going to help you understand the clinical reasoning process that underlies medical decision-making, to improve diagnostic reasoning skills in order to reduce cognitive errors, and to develop a system to check one's own diagnostic thinking in order to develop expertise. So as an introduction, there's many diagnostic errors that occur, unfortunately, when we take care of our patients. And these diagnostic errors can be broken up into three different other type of errors: no-fault errors, system errors, and cognitive errors. Overall, diagnostic errors are a small portion of the many errors that can occur. And many of the errors are related to medications and other patient safety issues, but we're going to focus on diagnostic errors for the purposes of this lecture. So when it comes to no-fault errors, basically what that means is that the illness is silent or masked or presents in such an atypical way that the correct diagnosis with the current state of medical knowledge would not be expected. System errors means that there are flaws in the healthcare system related to weak policies, poor coordination of care or communication, and other factors, including stress, fatigue, and workload. Cognitive errors is a misdiagnosis from inadequate knowledge, faulty data gathering, or inaccurate diagnostic reasoning. So for this lecture, we're going to focus on cognitive errors as a subset of diagnostic errors, which is, again, a subset of overall medical errors. So diagnostic errors as a subset of all overall medical errors have been reported to occur in about 10 to 15% of all patient cases. Over 75% of the diagnostic errors can be attributed to a cognitive error. So we must improve diagnostic reasoning skills to reduce these cognitive errors. And that's, again, what the focus of this lecture will be today. So diagnostic reasoning is the most critical of a physician's skills. It is every doctor's measure of their own abilities. It is the most important ingredient in their professional self-image. So doctors take pride on being able to make a correct diagnosis and reason through what is happening with their patient. So this is a very important skill that physicians must develop. So let's do a case. Our first case is an 18-month-old who comes in with abdominal pain for 1 day. He draws up his legs intermittently as if he is in pain. He has had a bad cough, diarrhea, and fevers for the past 4 days. He's had a decreased appetite for the past couple of days. He's vomited once today, and now he's more sleepy than usual. He had a loose stool with some blood in it the last time he had a bowel movement. Family history: there is insulin-dependent diabetes, hypertension, and renal stones. Social history: he lives with his parents, a 4-year-old sister, and they have 2 dogs and a turtle at home. So think about what might be going on with this 18-month-old child. Your choices are an acute viral gastroenteritis, acute bacterial gastroenteritis, intussusception, intermittent volvulus, or pneumonia. So take a moment to think about what might be happening with our patient and what the diagnosis might be. So a barium enema was done, and this is the finding on the barium enema. So based on this barium enema, let's look at the choices again and see what you think might be going on with this patient. What do you think is the most likely diagnosis? The correct diagnosis is intussusception. Based on the history, based on the exam, based on the barium enema, this patient had an intussusception. So let's look at some studies that evaluated why doctors might miss their diagnosis. And this is a retrospective self-report of causes of errors in the study of internists. So these are adults, physicians taking care of adult patients. And in this study, what they found in decreasing frequency as far as why they miss a diagnosis: number one, was that it never crossed my mind. A second one, I paid too much attention to one finding. Third, I didn't listen to the patient's story. Fourth, I didn't know enough about the disease. Fifth, I didn't reassess the situation. And sixth, I was influenced by a similar case. So this is one of the earlier studies that looks at why doctors miss the diagnosis. So we must improve diagnostic reasoning skills in order to reduce cognitive errors. But first, we must understand the clinical reasoning process that underlies medical decision-making. So let's briefly review that. So a theory called dual process theory is available to help with the hypothesis of medical decision-making. And in this dual process theory, it basically says that there are two systems at work when you're making a diagnosis on a patient. System one is an intuitive type of system. System two is more of an analytical type of system. So in the intuitive system, this basically uses unconscious thinking patterns and is more of a Gestalt type of effect or pattern recognition and uses illness scripts. It's kind of an instinctive first impression. And in this system one, which is more intuitive, the physicians tend to use more heuristics, meaning mental shortcuts. This is very different from system two, which is a much more analytical type of approach. In this one, the thought process is much more deliberate and it's purposeful. There's an analytical decision-making process, and it follows algorithms and a very logical approach. And it uses more normative reasoning or rule-based processing. So when you compare system one, which is intuitive, compared to system two, which is more analytical, there are differences. So when it comes to action, intuitive is much more reflexive versus the analytical approach is much more deliberate. So intuitive system one is very high when it comes to kind of automatic responses versus a low automatic response in system two or the analytical approach. System one, intuitive, is much faster in the thought processing compared to system two or analytical is much slower. System one, intuitive, requires minimal effort because it is fast, it's automatic, it's reflexive, versus system two requires a more effort and considerable effort to think through what's going on with the patient. So system one has some vulnerabilities to bias, and system two is much less vulnerable to these biases. System one can be much less reliable compared to system two. Errors can occur more commonly in system one compared to system two. And scientific rigor is usually a little bit lower in system one compared to system two. So there are some advantages and disadvantages of both systems. And really it's a balance between these two systems as you approach a patient and you think about what is going on and making a diagnosis for your patient. So in some circumstances, an intuitive approach may be more appropriate, whereas in others, an analytical approach might be preferred. And many times it's a blend of the two where you're kind of going back and forth between the two. So a lot of times intuitive system one is used when it's a straightforward case. It's much common, it's a common presentation and it's more intuitive. So you use system one. But when things aren't making sense or they're not coming together, or it just seems like there's something not right, then we tend to rely more on an analytical approach and use the system number two. So again, intuitive system one is more automatic, subconscious, used to solve common problems. It really relies on pattern recognition, heuristics, and illness scripts. So you see a patient, you recognize the pattern of the history and the physical exam, you use your mental shortcuts, you have illness scripts that you have developed in your mind, and then you very quickly and automatically come to a diagnosis on that patient. Analytical system two is a much more conscious, rational process. And it's much more slow and deliberate when things aren't coming together and they're not making sense. So then you start thinking about different solutions and you check on the solutions and you kind of work through it very deliberately and very slowly. And this is the primary process that's used when it doesn't lend itself to an automatic solution. So pattern recognition, I mentioned as something that we use for the intuitive system one. So pattern recognition is used outside medicine as well. So here's an example. According to research at Cambridge University, it doesn't matter in what order the letters in a word are. The only important thing is that the first and last letter be at the right place. The rest can be a total mess and you can still read it without problem. This is because the human mind does not read every letter by itself, but the word as a whole. So this is a great example of pattern recognition and how we look at words and identify the pattern and come up with what word it is, even though the letters might not be in the proper order. illness scripts. So this is something else that we use to help make diagnoses. So let's say you have a patient coming in who has a fever. Also, they complain of a sore throat. And there's absence of cough and congestion. And on exam, they have cervical lymphadenopathy. You look in their throat and they have tonsillar erythema with palatine petechiae. So what's the most likely diagnosis on this patient, given this illness script that they are presenting with? It's going to be strep throat. So we commonly will make the diagnosis of strep throat by using these type of illness scripts and very quickly and intuitively make the diagnosis of something common like a strep throat. So how do we reduce cognitive errors? So it's first we have to understand that medical students who are novices use deductive reasoning to solve clinical problems. And this is very time consuming and error prone. The opposite end of the spectrum are medical experts who use extensive experience and more complete knowledge base to solve clinical problems. And these experts are thinking through the process very quickly, very easily, and they have a low likelihood of making an error in making the diagnosis for the patient. This is a nice diagram that kind of gives an overview of the thought processing and clinical decision making that goes into place when a physician sees a patient. So in the more novice, inexperienced type of beginner, you use more deductive reasoning up on the upper left, and that is much more time intensive and takes a lot of energy, and the reliability and accuracy of your diagnosis is going to be low. So this would be more of a novice or a student who uses more deductive reasoning. As they get more experience and more knowledge, then most of us move up from the deductive reasoning portion to the pre-expert reasoning area, or the heuristics portion in the middle of this diagram. And in this, there's kind of a moderate effort and time and energy that is expended to allow for a more moderately reliable and accurate diagnosis. And most of us are in this middle section of the pre-expert reasoning. This is where we kind of normally function. But you can actually improve your accuracy and reliability of diagnostic reasoning by reflecting on your patient, monitoring what's happening with your patient, monitoring your own knowledge base and experience, and then become more reliable and accurate in your decision making. But that takes time and effort and energy. So by expending some time and effort and energy, you can become more reliable and accurate in your diagnosis and in your decision-making abilities by using monitoring and reflection. Now, experts, they are very quickly and easily and with minimal effort are able to make an accurate and reliable diagnosis because they have expert thinking. So these experts, again, are able to make a diagnosis that is very reliable and accurate, and they could do it with minimal time, energy, and effort. So how can we move from the pre-expert phase to this monitoring reflection where we are more reliable and accurate in our decision making, but that again takes effort and time and energy, and that is system 2. So basically, when you use system 2, you are deliberately and analytically and thoughtfully approaching the patient, and you are reflecting on what's happening with the patient and monitoring the response of the patient, and using system 2 to help you make a more reliable and accurate diagnosis. But again, that does take more time and effort and energy, but you can improve your diagnostic reliability and accuracy by using system 2 to help you with that. So the reliability of medical diagnosis can potentially be improved by invoking more analytical thinking through the use of system 2. And that's what the previous diagram in the green arrow was indicating. So this conscious reflective review allows a cross-check of the results to catch errors, to consider alternatives, and to recognize and address potential biases. And all of this can reduce cognitive errors by using system 2 to come up with a more accurate and reliable diagnosis, but by putting in a little more energy and effort and thought in the approach. So I mentioned biases. So there are these cognitive dispositions to respond, or CDRs, that have been described in the literature. And these are basically cognitive biases. And these are biases that can be a source of diagnostic errors. These biases are really adaptive strategies to reach reasonable, if not entirely rational conclusions. But clinicians must be familiar with these CDRs or these biases and learn how to avoid them. Because again, this could be a source of diagnostic errors if you fall victim to some of these biases. So being aware of them and understanding them and learning how to avoid them can be very helpful in reducing diagnostic errors. So there's been many CDRs or cognitive biases that have been described in the literature. Some literature suggests there's more than 40 or 50 of them. So some examples of these CDRs as biases include availability, confirmation bias, anchoring, diagnosis momentum, and premature closure. We're going to talk about each one of these briefly. So availability is the tendency to judge diagnoses as more likely if they readily come to mind. Recent experience with the disease may inflate likelihood of its being diagnosed. And conversely, if a disease has not been seen for a long time, meaning it's less available in your mind, then it may be underdiagnosed. So this can happen. Let's say you're seeing pediatric patients in an ER setting in the middle of RSV season, and you have infants coming in with wheezing and respiratory distress, and the last 5 patients you saw were with RSV bronchiolitis. But another patient comes in with wheezing and respiratory distress, and you assume the child has RSV because that's what you've been seeing, so it jumps to your mind again, but maybe the patient is actually in CHF and is in heart failure and is having the wheezing and respiratory distress related to that. So you might miss that diagnosis because that's not what you're thinking, right? Or it's not a common diagnosis, so you haven't seen a diagnosis in a long time, and then it doesn't pop into your mind and when a patient presents with the symptoms of an alternative diagnosis. So that is availability bias. The next one is confirmation bias. So this is the tendency to look for confirming evidence to support a diagnosis rather than looking for disconfirming evidence to refute it, despite the latter often being more persuasive and definitive. So again, we tend to try to confirm our diagnosis, and we do testing to confirm it. And even if that testing comes back negative, we still say, no, the patient still has this disease or this illness, despite the imaging or the labs not supporting it. But I still think the patient still has this diagnosis. Then it's just a lab error, it's something else. Why it's not the finding that I would expect at this point. So that's a confirmation bias. Anchoring is a tendency to perceptually lock onto salient features in the patient's initial presentation too early in the diagnostic process and failing to adjust this initial impression in the light of later information. So basically it means that you anchor onto a diagnosis early on and you are stuck on that diagnosis, you fall in love with that diagnosis, and despite what labs are showing, what testing is showing, you don't adjust your initial assessment and you stick with that initial impression that you had, that initial diagnosis that you thought the patient had, and that you anchor onto that diagnosis. Diagnosis momentum. So this is when a diagnostic label is attached to a patient and it tends to stick. So through intermediaries, meaning patients, nurses, or physicians, what might have started as a possibility gathers increasing momentum until it becomes definite and no other possibilities are considered. So basically a patient is labeled with a diagnosis and that patient just carries that diagnosis as they come up from the ER and they go up to the floor or they go to radiology or wherever they go. Everybody assumes that's what the patient has, although that was not really a final diagnosis. It was a presumptive diagnosis. So that diagnosis just picks up momentum every time somebody sees them, and they just assume that that pre-labeled diagnosis for the patient must be what the patient has. Premature closure. This is one of the most powerful biases or CDRs leading to missed diagnoses. The tendency to apply premature closure to decision-making process and accepting a diagnosis before it has been fully verified. So basically what happens is that you stop too soon without appropriate consideration of alternative possibilities. So again, you prematurely close your thought process and you make a final diagnosis and you stop thinking about what else might be going on at the patient or looking into other possibilities too soon, and then you end up missing the actual diagnosis. So premature closure is one of the most common and most powerful biases that we as physicians can fall victim to. So it's a very important bias or CDR to keep in mind. Okay, so now let's do our second case. So in the second case, we have a 10-month-old coming in, actually being transferred from an outside hospital emergency department with a bad cough, diarrhea, and fevers for the past 4 days. Yesterday, he was drawing up his legs as if he was in pain. but then got better after having a loose stool. He's had several episodes of non-bilious vomiting today. He's been less active since this morning, but now is very sleepy. A KUB is done at the outside hospital and is suspicious for a possible intussusception, so is being transferred to your facility because they cannot do a barium enema. So they are transferring the patient because the patient needs a barium enema to rule out the intussusception based on the KUB findings. Family history of diabetes, hypertension, and renal stones. Social history, lives with parents and 4-year-old sister, and they have 2 dogs and a turtle at home. So the patient arrives in your hospital and you do a barium enema, and this is what the barium enema shows. So based on the findings of the barium enema, these are your choices that you can choose from. Acute bacterial gastroenteritis, intussusception that's spontaneously resolved, pyelonephritis, intracranial hemorrhage, pneumonia, or L kappa, which is an anomalous left coronary artery rising from the pulmonary artery. So based on the history, the exam, and the imaging, think about what you think might be going on with this patient. So this patient was admitted to the floor for observation with the diagnosis of spontaneously resolved intussusception. So based on the barium enema and the history, that was a working diagnosis when he was admitted to the floor. But on the floor, he continued to be sleepy, and a CT of the head was done at that time. And it found an intracranial hemorrhage or an epidural hematoma, as you can see on this CT. So now looking back at your choices, this patient had an intracranial hemorrhage causing his symptoms of the vomiting and the lethargy, and came in with this intracranial hemorrhage then. So we missed the diagnosis initially and said it was a spontaneously resolved intussusception. So why did we miss the diagnosis? Was there a bias or CDR that caused us to miss the diagnosis? Was there an availability bias? Possibly, right? Because case number 1 that we talked about in this lecture was an intussusception case. So maybe intussusception was more readily available in your mind, and you thought about that as the working diagnosis on this patient. Confirmation bias. So again, we presumed the patient had an intussusception based on the history in the KUB. So we did a barium enema. Even though it did not show an intussusception, the confirmation bias that we might have had said, well, maybe there was an intussusception that we missed, and it was actually spontaneously resolved by the time we did the barium enema, so we made the diagnosis that way. Anchoring. We anchored on to the diagnosis of intussusception based on the outside hospital and the KUB. Then we anchored on to the fact that he must have an intussusception, and the barium enema didn't see it, so it must have resolved by the time we did it. Diagnosis momentum, again, the patient was labeled from the other hospital as a rule out intussusception. So again, we presume that's what the patient had, despite the barium enema not showing intussusception. So there was diagnosis momentum. And premature closure. We might have closed our thought process too prematurely and then did not entertain other things that might be causing lethargy and vomiting in this patient. So again, going back to our diagram that we talked about, we can use system 2, like I said, to reflect on the case and to monitor our experience so that we can learn from that case and become more accurate and reliable in our diagnostic decision making and in making the appropriate diagnosis. So system 2 again can help us with that when we spend more time and effort and energy to reflect on and monitor the case. So system 2 can help us with that. Another word that can be used to help us with this reflection process is metacognition. So metacognition is basically using system 2 analytical type of approach to reflect on the patient to be able to more accurately and reliably diagnose what is happening with your patient. So metacognition is the ability to step back and reflect on what is going on in a clinical situation. So basically, it's kind of thinking about your own thinking, right? So reflecting and thinking about your thought process, and it's learning from experience. Part of metacognition is checking to see what is happening with your own diagnostic thinking, what is happening with your clinical reasoning skills, and it's looking to see if there's any possible biases that might be impeding your ability to make a diagnosis. It's through metacognition, you can identify other limitations and failings. Metacognition forces you to develop a complete differential diagnosis and to search for other alternatives. So through metacognition, through system 2, through reflection, through thinking, through deliberate thought processing, you can come up with a more complete differential diagnosis and search for other alternatives and make sure you don't have any biases that might lead you to missing of the actual diagnosis. So let's do our third case. So we have a 24-month-old being admitted from our emergency department for fever, fussiness, and abdominal pain for the past 2 days. The patient has been eating less than usual and now vomited several times. Also, he had a loose stool today. Physical exam revealed a febrile child with a temp of 38.9 Celsius who was moderately ill-appearing and dehydrated. The physical exam was limited, especially with the abdominal exam, because the patient was crying. The CBC showed an elevated white cell count of 16,000. A UA or urinalysis showed moderate leukocyte esterase and ketones on the urine dipstick. So this is what we have to work with on our patient. So what do you think might be going on with this patient? So these are the choices that you can choose from. An acute viral gastroenteritis, intussusception, pneumonia, pyelonephritis, appendicitis, or DKA. So take a moment to think about what you think might be happening with this patient. So the patient was admitted to the floor and started an IV ceftriaxone with the diagnosis of pyelonephritis given the white cell count on the CBC and the urine dipstick findings. The patient also had a renal ultrasound, which was normal, did not show any pyelonephritis or anything abnormal. And the urine culture ultimately came back negative after a day or two. So despite 3 days of IV ceftriaxone and a negative urine culture, the patient remained febrile and continued to have this abdominal pain and poor PO intake. A CT of the abdomen was done at that point, and it showed a ruptured appendix with abscess formation. So now, looking back on our choices, the correct diagnosis for this patient was actually an appendicitis. So we missed the diagnosis of appendicitis based on the presentation of the symptom of this patient and the symptoms and the findings that he had, and he actually had appendicitis. So again, using metacognition to think about why you missed the diagnosis, or as you are approaching the patient and caring for the patient, using metacognition to make sure you don't miss the diagnosis. So something that's suggested in the literature is taking a diagnostic timeout. Now, we're used to taking timeouts when it comes to procedures, making sure it's the right patient, the right procedure, things like that. But there's also a suggestion that we should be taking a timeout when it comes to diagnosis. So taking a diagnostic timeout. And what does that include? Number one, asking yourself, does the diagnosis make sense? Number two, are these lab results what I expected? Number three, did I have any biases or CDRs? Number four, am I comfortable with this diagnosis? And number five, if the patient is uncomfortable or is not buying your diagnosis, at least rethink these things. Excuse me. So again, taking a diagnostic timeout is very important because it can help you make sure that you're not missing the diagnosis. So take a step back, take a timeout. Once you come up with your diagnosis, does it make sense? Do the labs all come together? Do they corroborate with what you think is going on with the patient? Could you have any biases that might have led you astray and caused you to miss the actual right diagnosis? Are you comfortable with the diagnosis? Does it make sense? Is something bothering you about the diagnosis? And if the patient or the parent is uncomfortable for some reason, they're not buying your diagnosis, please step back and rethink, why are they not buying into it? Is there something that I'm missing that they don't feel comfortable with my diagnosis? So the underlying thought process of experts that enables them to learn from experience and ultimately to act on an intuition is metacognition. So metacognition helps you become an expert. Through the use of metacognition, you become an expert because you learn from your experience, and that ultimately allows you to act on intuition. So expertise is defined by one's capability to think as well as by the outcome of one's thinking. So it is the ability to act rapidly with no apparent thought in emergent situations. So it's basically being able to think quickly and come up with the right answer, especially in a crisis or emergent situation, and do it in a very quick way without any apparent thought or delay. Experts carefully and systematically monitor and regulate their experience, but also act quickly and intuitively when necessary. Medical experts require metacognition and intuition as two complementary operating systems. Expert intuition is developed by using metacognition. So again, experts use intuition or system one, but they also use system two or metacognition, and they use them in a complementary way as they are interacting with their patients. And once you have expertise and expert intuition, then you can make diagnosis very quickly and very accurately. And the way to develop this expert intuition is by practicing the use of metacognition. So again, going back to our diagram, by using metacognition, over and over again with each patient, reflecting on the patient, learning from the experience of that patient, using metacognition, that allows you to become more accurate and reliable in your diagnosis. Initially, it takes a lot of time and effort to do that, but ultimately, when you use it enough, you become an expert and you develop expert thinking. So that's how you develop expert thinking, is by using metacognition on a regular basis. And then once you develop expert thinking, then you go down the path from the top left to the bottom right in a very smooth way, where you quickly think about the patient and are accurate and reliable in your diagnosis, but with little time, effort, and energy once you develop expert thinking. But in order to develop the expert thinking, you must practice metacognition. Okay, so our last case, case number 4, we have a 4-year-old male who presents to the emergency department with intermittent abdominal pain for the past day. He points to his right upper abdomen every time it hurts. He has had 3 episodes of pain in the past 24 hours. The last episode started after he was running around and playing with his 7-year-old sister. For each episode, the pain lasts about 1 hour. The patient lies down and draws up his legs when an episode of pain occurs. He vomited once with the last episode. He denies diarrhea, urinary symptoms, rash, or weight loss. He has had a URI for the past week, but that seems to be getting better. Mom has been pushing oral fluids while he's had the URI. Past medical history, he had 2 similar episodes of intermittent abdominal pain over the past year. Each resolved on its own within 24 hours. Family history of diabetes, hypertension, and renal stones. He lives with his parents and 4-year-old sister, and they still have the 2 dogs and a turtle at home. So now let's see what you think is going on with this patient based on the history that is being provided here. So your choices are intussusception, gastritis or peptic ulcer disease, cholelithiasis, HSP, hydronephrosis, or pancreatitis. So take a moment to think about what you think this patient has. So the initial diagnosis was possible intussusception based on his symptoms. So the barium enema was done, and this is what the barium enema showed contrast going through the entire colon. So given the negative barium enema results, the patient was sent home from the ED with a diagnosis of viral gastritis. But he returned to the emergency department 1 month later with similar symptoms. And at that point, a CT of the abdomen was done. And this is what the CT of the abdomen showed. It showed a dilatation of the right renal pelvis, consistent with and secondary to a UPJ obstruction, or ureteral pelvic junction obstruction. So now looking back at our choices, this patient ended up actually was diagnosed with hydronephrosis, or renal pelvic dilatation secondary to a UPJ obstruction. So this patient actually, when you look back at the history, has this intermittent abdominal pain, right upper quadrant. So it's kind of renal colic type of pain that he was having. And with UPJ obstructions, they can many times present similar to intussusception, where they have this acute colicky type of pain where you kind of curl up and draw up your legs and you have this pain. But it's not related to intussusception. It's actually related to acute hydronephrosis or acute renal dilatation, renal pelvic dilatation, and acute pain, and more a renal colic type of presentation. So what was happening with this patient, he had been sick recently, and then mom was pushing fluids. So because he was being given extra fluids, then also he's running around at that time when the pain occurred during these episodes. He had increased GFR, increased urine production. So he actually had a ureteral pelvic junction obstruction, but normally when he has normal urine production, it wouldn't cause renal pelvic dilatation. But acutely, when you have increased GFR, increased urine production, then that area that is obstructed can no longer allow the amount of urine to pass, so you get acute dilatation of the renal pelvis and pain. So that's what these previous episodes were related to as well, and the ultimate diagnosis was made based on this patient, but he presented as if he might have had intussusception. So again, it's very important to look at the history and use your clinical reasoning and diagnostic skills to think about what might be happening with the patient. And again, using metacognition or using a diagnostic timeout. So does the diagnosis make sense? Are the labs or the imaging or the results what I expected? Did I have any biases or CDRs? Am I comfortable with the diagnosis? And if the patient or the parent is uncomfortable or is not buying the diagnosis, then at least rethink things at that point. So I think these 5 questions are very important as part of metacognition and diagnostic timeout, and something that we should do on a regular basis either with yourself or with your team as you are finalizing a diagnosis on a patient. Okay, so to kind of summarize here, this article summarizes 12 tips and strategies for reducing diagnostic errors. So in this article, number 1 that is mentioned as a strategy to reduce diagnostic errors is emphasize the importance of the history and clinical exam. So again, history and exam are the most important factors that you should use in making the correct diagnosis. And then again, if you remember Sir William Osler's quote from the first slide, that if you listen to your patient, they will tell you the diagnosis. So through the history, through the exam, they're telling us their diagnosis. We just have to listen. Other strategies, number 2, promote a systematic approach to common problems. So again, be very methodical, very systematic, even to common problems to make sure you're not missing something. Number 3, expand your knowledge base. So keep reading, keep learning about disease processes, keep expanding your knowledge base. Number 4, promote the use of timeouts, as we've been talking about. Ask the team to step back and rethink the diagnosis. Number 5, avoid premature closure. So again, that's one of the most common CDRs or diagnostic biases that we have. So avoid premature closure. Number 6, consider using the worst case scenario strategy to generate a differential diagnosis. So I think this is a very effective strategy as well, where you think about what's the worst thing that this patient could have, the worst thing on the differential diagnosis, and rule that out, and at least think about that from the history and the exam and make sure you do not miss that. Number 7, take care not to order unnecessary studies that might lead to an error. So sometimes when you do unnecessary studies, something comes back abnormal, then you have to try to explain it, and that could be difficult sometimes. Number 8, ask why. Why does the lab not make sense? Why is that finding there and I can't really explain it based on the diagnosis I'm considering? So ask yourself why when you're thinking about the patient then. Number 9, acknowledge your feelings about a patient or family. So sometimes we have biases related to our interaction with patients or families, right? We might be tired, we might be fatigued, and somebody, we're frustrated with a patient or a family, and that then can be a barrier in making the right diagnosis, and that introduces biases when we have different feelings about our patients or our families. Number 10, slow down, right? Think about what's happening, take a breath, and be more deliberate and more thoughtful in your diagnostic reasoning. And the last 2 here, number 11, understand the cognitive process that can lead to a diagnostic error or CDR. So be aware of these biases and these CDRs and understand that they exist and try to avoid them. And number 12, admit your mistakes. When you make a diagnostic error, reflect upon the event. So we're going to make mistakes. We're gonna miss things. So learn from those, right? Reflect on those, and that's what metacognition again is all about: is reflecting on it, monitoring patient outcomes, and learning from them, and really learning from experience. So with that, I wanted to show you the references for my talk and for my slides. And I want to thank you for participating in this CRASH course today, and hope to see you at other CRASH course cases as well.